আমরা জানি encephalitis এমন একটা রোগ যেখানে ডায়াগনোসিস ইজ ডিফিকাল্ট, ট্রিটমেন্ট অলসো ভেরি ডিফিকাল্ট। সুতরাং এরকম একটা পরিস্থিতিতে যখন বিভিন্ন সময় বিভিন্ন রিজিয়নে এনকেফালাইটিসের প্রাদুর্ভাব দেখা যায় তখন অনেকটা আমরা বিপদে পড়ে যাই। আমাদের আজকের আলোচনা ইমার্জিং এনকেফালাইটিস ইন বাংলাদেশ ইনক্লুডিং নিপা এনকেফালাইটিস। I try to focus more on nipah encephalitis. Nipah encephalitis, there are 4 pictures below. One is the passion, another is our favorite juice, যেটা আমরা পাম জুস বা খেজুরের রস এবং পাম ট্রি, and there is a vector or bat, fruit bat. এই চারটার মধ্যে একটা ইন্টারলিঙ্ক পাওয়া যায় যখন আমরা এই যে নিপা এনকেফালাইটিস নিয়ে ডিসকাশন করি। প্রথমে আমরা একটু দেখি হোয়াট ইজ এনকেফালাইটিস। এটা কনভেনশনাল এনকেফালাইটিস ইজ দ্য ব্রেন প্যারেনকাইমাল টিস্যু ডিউ টু ইনফেকশন আইদার ব্যাকটেরিয়া, ভাইরাস or fungus or protozoa, but the viruses is the predominant role in the encephalitis and always equivalent to encephalitis means actually it is viral encephalitis. So there might be primary viral encephalitis due to direct involvement of the virus through blood stream and CSF involvement and destruction of the brain parenchymal cell. Another possibility of the viral mediated inflammatory response which can also occur, which we called it secondary or post-encephalitis syndrome or post-encephalitis disease. For the surveillance purpose, World Health Organization given some parameter to justify clinically of a case of an acute encephalitis. There are 3 criteria. One is the acute febrile illness and a change in the mental state, which can be characterized by confusion, disorientation, inability to walk, coma, etc., and or new onset of seizure, excluding simple febrile seizure. This is World Health Organization definition for in the epidemic period during surveillance purpose. And what are the viruses responsible for encephalitis? More than 100 different viruses can cause acute encephalitis, and it is variable in different countries, different region of the same country. As for example, Western virus is more common in USA, but it is not common in our country or very less. And some common encephalitis virus we are facing problem. One is the arbovirus, that is the Japanese encephalitis virus, dengue virus, mumps, varicella or rubella virus, herpes simplex virus. It is one of the commonest infection causing the encephalitis in our country. Sometimes the influenza virus, and the most deadliest virus is the rabies virus, and sometimes the enterovirus and the polio virus. But most of the time there may be lots of unknown virus which we cannot detect or specify what are causes of this encephalitis. So these are the few examples of common viruses in Bangladesh, but we are lack of diagnostic efficacy in our country, so very difficult to diagnose or confirmation of the viruses. And there may be some non-viral causes also, like tuberculosis, meningitis, brucellosis, even the severe typhoid fever, leptospirosis, and also the Lyme disease, which is common in USA, and some fungal histoplasmosis. Also the commonest parasite, though nowadays it is less, the malaria parasite, toxoplasmosis, and amoebiasis. So these are also the non-viral causes which can also mimic or can cause the encephalitis-like syndrome. Who are the most risk factor for this encephalitis? Children is the most common, and the extreme of age, the elderly people, patient with immunosuppressive state like HIV, or immunosuppression by drugs like steroid or anti-cancer drugs, or person living in encephalitis endemic zones like nipah virus in our northern part of Bangladesh. So there are some risk factors. It is not usually common in immunocompetent virus, immunocompetent population. So far, there are 2 guidelines published, one from the Director General of Health Service in 2012, the National Guideline for Management, Prevention and Control of nipah encephalitis infection, and another one published by IDCR in 2016, a national guideline. So on the basis of 2 guidelines, I like to proceed my presentation. These are the details description from 2001 to 2022, which is in different regions of Bangladesh and district. Around 32 districts suffer from different case report for nipah encephalitis. Actually, first, this nipah virus occurrence occurred in 1988 and 19 to 99 in Malaysia and Singapore. More than 300 cases at that time recorded, and one of the villages, Sungai area of nipah village, the death rate was very high. According to that place, that village name, it is the nipah virus given. And 2001 till today, every year there is some evidence of nipah encephalitis or nipah respiratory distress syndrome, and we are showing actually the total Bangladesh. In the map, the red area is very highly affected area, and total case reported, it is the source from IDCR, 325, and death was 230. So the death rate was very high, 70%, more than 70% people die. And so it is the number of cases from 2061, it is 69, and 2022, still there is 67 cases. In between, only 2 to 3 years, like 2006, 2016, there are no case report, and also 2002. So last 20 years, there is every year there is some occurrence of the nipah encephalitis. So in the beginning of this year, 2023, there is a case record up to 6th February, 10 cases from Rajshahi, Nagaon, Rajbari, Pabna, and Shariatpur, and Natur. Out of 10, 6 was male and 4 was female, and 7 cases died. So mortality rate also the same, the 70%. So it is our awareness about the prevention and of the cases, because there is no effective treatment till today for the nipah encephalitis. Actually, their group belongs to paramyxovirus, which include 4 measles, mumps, and Henipah virus. And this, under the heading of Henipah virus, there is 2 viruses. One is the nipah virus, one is the Hendra virus. But Hendra virus is more common in the horses. In the Australia, there is a case report. So in Bangladesh, in India also, and in Singapore and Malaysia. This is the structure of the nipah virus, because if we know the structure and genomic structure of the virus, so the vaccine preventing this disease is important. And there is a 4 layer of proteins. One is the envelope protein, another one is matrix protein, and inside that there is a ribonucleoprotein. So there are different protein embedded in the different layers, which are functioning. Some are attachment and host cell entry, some are producing mediate morphogenesis and budding, and also some producing, there is a different pathological changes in our body. And if we look at the genomic structure, there is a 6 nucleoprotein structural protein, and it is very important to produce vaccine against the nipah virus. I am not going details of the virus structure. It is actually single-strand, non-segmented RNA, about 18 kilobyte it is size. And these are the vector which are the natural source of this Nipah virus. They do not suffer from the diseases. They are called fruit bat or pteropus group family, and there are different types of member in this family. And they are hanging in the trees and they are eating fruits. So also they are eating our khejur rosh during winter season, just we are passing. And fruit bats is the main reservoir of NIV. Out of Bangladesh have identified 2 routes of transmission of Nipah virus in our country: drinking of raw date palm sap, or that is khejur rosh, contaminated with Nipah virus, and close physical contact with Nipah infected patient. That is our main concern, human to human transmission. So it is very dangerous. And 2 systems of the body is mainly affected. One is the CNS, another one is the respiratory system, that is leads to ARDS like COVID virus and causing death of the patient. So 2 routes in our country and 2 systems is mainly affected. And if we look at the pathogenesis of this virus, it is the transmission of the Nipah virus is transmitted to the human body. It is first start fruit bat with Nipah feeds on date palm juice. During night time, they also eat palm juice, and they excrete. They urinate within this container, and also they contaminate the juice. So when in the next morning, this juice is taken, and someone taking this juice raw without boiling, so they are ingested the juice and they contaminate, the virus may be entering into the body. So human will be affected. Another way, when some fruits are fallen down on the ground, half-eaten fruits, then the fruits may be taken by the pig, which is what is happened in Malaysia in the pig farm, and the pig are contaminated, infected, then they killed all the pigs of that farm, and also this contaminated, those who are handling the pigs, they also infected by the pig. Even after eating the meat of the pig, they also may be contaminated. So, and this meat may be exported to the different places of the world, so they also may be affected by other parts of the countries. So in this way, the bat to human through the dead palm juice, or from bat fruit, then the pig, then the human is contaminated. So these 2 routes is responsible for contamination, transmission of this Nipah virus in the human body. And if we look at the pathogenesis of the virus, the initial stage, the Nipah virus epithelial cell of the bronchiole, and they also causing the atypical pneumonia like COVID, coughing along with acute respiratory distress. Secondly, there may be in the bronchi and alveoli, main target epithelium of the bronchi and type 2 pneumocytes. So they have some similarity with pathogenesis like COVID virus. Later on, they infected the airway epithelium, and they release various types of inflammatory mediators, interleukins, and other cholinesterol factors. And ultimately, they enter into the bloodstream, and within the leukocyte, they are transmitted to the brain, entry to the brain, and causing the neuronal damage. And also, they release their TNF alpha and the interleukin beta. Any other organs of body affected, the spleen, GI tract, they cause bleeding. Also, there is involvement of the kidney with severe septicemia and renal failure. So, when this virus is loaded with leukocyte is loaded with virus, they are passively transferred to different parts of the body. So, in this way, the pathogenesis of Nipah virus occur in our body. And if we look shortly, basic pathology, there is a two types of lesion. One is the vasculitis, that is thrombosis and obstruction, and there is a later on ischemia and infarction of the affected area, and also extravascular manifestation. They directly damage the parenchymal cell and cellular injury. So almost they have similar presentation like our COVID virus. And there is a common symptom in every cases of encephalitis, especially the children. There will be sudden development of fever, headache, vomiting, diarrhea may be present, lethargic, and also sometimes irritable restlessness, and the tremor or convulsion can occur. This is common symptom for most of the types of encephalitis. And also changes in consciousness like semi-conscious or even deep coma can occur. But in the order of frequency in Bangladesh, the symptoms shown in the different case series: fever, altered mental state, severe weakness, headache, respiratory distress, cough, vomiting, muscle pain, convulsion, and diarrhea in the nipah infected patients. And in the signs, there may be GCS, reduced GCS score, raised temperature, respiratory rate, tachycardia, tachypnea, lung crepitations, both hypertension and hypotension occur during shock period. There are also some predominant neurological manifestation also occurred: pupillary abnormality, facial weakness, bulbar weakness, limb weakness, reduced tendon, deep tendon reflex, and also the plantar and extensors absent. So these are the findings found in different case series in Bangladeshi population during nipah infection. As it is difficult to diagnose, so there is some epidemiological criteria given to early detection of the cases. So there are three types of nipah encephalitis group. One is a suspected group, which is defined by World Health Organization criteria, features of encephalitis. As mentioned before, it is fever, acute brain dysfunction, which is altered mental states, or new developmental seizure, and any neurological deficit. So we'll suspect this is a case of in an endemic zone of occurring of nipah, which is previously shown in our map. And there is some epidemiological link might be present. One is drinking of raw dead palm, and also during season. It is more common in May to December, especially the winter season, when we collecting juice from the palm tree. And also there are some endemic zone in the Bangladesh, about 32 districts, there is a case report. So in this area, if any suspected acute febrile illness with neurological dysfunction, we suspect case of acute encephalitis syndrome might be due to nipah encephalitis. Probable case, if there is a other case report or outbreak report, and there is a confirmed contact with the nipah patient, and or father or mother or children, or there may be some respiratory feature like illness less than 7 days, acute onset of fever, sudden onset of shortness of breath, cough, and chest radiograph showing diffuse infiltrate like ARDS. So this case definition is given. Actually, we can easily, clinically we can suspect. And the confirmed case is by the laboratory confirmation of IgM antibody, either in the serum or cerebrospinal fluid, or the PCR confirmation in the CSF, respiratory secretion, or urine. And when there is a 2 or more cases living within a 30 minutes walk of each other who develop symptom within 200 days, then we cause a cluster of cases. So if there is a epidemiological surveillance done, if there is any suspicion case, and there might be some differential diagnosis always, we exclude the bacterial infection, and the meningitis, tubercular meningitis, or cerebral abscess, even the cerebral malaria, intracranial acute stroke syndrome, or trauma, or any toxic ingestion, alcohol, or any other poisoning cases. So many of the differential will come, but we have to exclude by the epidemiological link, endemic zone area, and history is very important. Another confusion arises when there is a encephalopathy and encephalitis. One, it is for the postgraduate student, how we differentiate encephalopathy, like hepatic encephalopathy, hypertensive encephalopathy, or the uremic encephalopathy patient from the encephalitis. Encephalopathy predominantly causing the functional disorder of the neurons, and it is mostly reversible. But on the other hand, encephalopathy, there is a fever is very uncommon, but on the other hand, the encephalitis, there is a fever is common, headache is common. And both the cases, there may be a deterioration of consciousness, but in encephalopathy, it is gradually deteriorated, but in case of encephalitis, it is sudden onset and deterioration may be fluctuating. Focal neurological sign usually common in case of encephalopathy. On the other hand, it is not common. And there may, both the cases, there may be convulsion. So our blood examination and the CSF examination, MRI, and other history will help us to differentiate between the encephalitis and encephalopathy. Usually encephalopathy, MRI finding almost normal, but there is some abnormal focal abnormality finding in encephalitis. So it may be confusion with encephalopathy also. We know what are the causes of encephalopathy. I am not going details, metabolic causes, hypoxic causes, toxic causes, or even the hypertension. Sometimes it may be confusion arise with the meningitis. Meningitis, viral meningitis and viral encephalitis, but they have almost similar features in case of encephalitis, viral meningitis, but photophobia, negastritis predominantly present in case of viral meningitis. And seizure usually least common or maybe late manifestation, and neurological features usually common in case of encephalitis. And usually the meningitis patients are confused, not totally coma or seriously deep unconscious. So there is a level of degree of confused state. We can some differentiating point from the meningitis and encephalitis. There are some viral encephalitis. One of the common viral encephalitis in our country is the Japanese encephalitis, especially the children under 15, which is common. And it is also one of the important cause of encephalitis in Bangladesh, and herpes simplex virus encephalitis. So incubation period usually 10 days, 2 to 21 days in case of nipah, but Japanese it is a bit less, shorter period, and herpes simplex more shortest period of incubation period. And history of drinking of raw dead palm in case of, but Japanese encephalitis is usually mosquito-borne disease, and there is no human-to-human transmission not reported. But herpes simplex encephalitis, there may be human-to-human respiratory droplet infection. One of the important and characteristic finding is the MRI finding, by which we can differentiate them. One is the important finding is the cortical and subcortical, some punctate lesion in case of nipah virus encephalitis. Later on, we show the MRI diagram. Or in case of Japanese encephalitis, it is the thalamus, cortex, and cerebellum. And also the herpes simplex, we all know, it is the mostly temporal lobe, that is a frontotemporal region is commonly affected. Clinical features, it is very difficult to differentiate, but there are some times we can differentiate by involvement of the different region of the brain. And the differentiating point is diagnostic confirmation by the PCR for a specific virus. So most of the time there will be leukocytosis in the CSF and also raised protein, but all the times the glucose are normal. But especially in case of herpes simplex and encephalitis, there is maybe presence of RBC cell, which is absent in other two types of encephalitis. So it is not difficult by doing MRI, CSF study, and also the PCR to differentiate between the nipah, Japanese, and herpes simplex encephalitis. So we have to do all the common routine examination for exclusion and inclusion of the encephalitis and other encephalopathy and the bacteria, viral cause, bacterial or parasitic fungal causes of encephalitis. Also, we have to do the special investigation like antiviral antibody and serology to find out the cause of this encephalitis. In addition, the three tests is very important for encephalitis patient. One is the CSF test we already shown, the changes, MRI of the brain, and the EEG. They might be helpful, but first two is very important. So diagnosis of nipah encephalitis, mainly two tests. One is the ELISA test, one is the PCR test. Other tests are not so practiced commonly. And enzyme ELISA test is done by IgM capture ELISA or indirect IgG ELISA from the serum or CSF, and they also can detect both the virus in hand and nipah from the CSF and serum. PCR also confirmation of the viral in the CSF, even throat swab as the nipah virus infected the respiratory epithelium, even the urine specimen. These are the shadow of 4 patients of suffer from nipah respiratory distress syndrome. And if this up to this level patient develop, the mortality is very high due to ARDS. And so there are many viral finding. I am not going details, MRI characteristics, MRI finding, and laboratory testing of different viruses. And these are the MRI finding, cortical and subcortical. There is a punctate lesion in case of especially nipah. In other cases, you will get a specific lesion. And these are the patient 1, where we see the multiple punctate white matter lesion in T2 image and FLAIR image of figure A and B, and more prominent in the B. Also, there is another patient, there is a multiple punctate lesion in the white matter. So these are the 2 characteristic finding, MRI finding in case of nipah encephalitis. So these are the other MRI patients, other patients MRI. Now, after diagnosis, we have to, as there is no specific treatment, we are going to go for an supportive and general management, like for an unconscious patient, for an infectious patient. And it is also important isolation, because there is a human-to-human transmission, and the doctors and nursing should be personal protective equipment and hand washing practice before and after visiting the patient. There should be resuscitation of the patient if there is needed, and patient should be ideally in the ICU or SDO ward and in an isolated ICU. And symptomatic treatment for the fever, convulsion, anticonvulsive drug, and also we can maintain by diazepam or phenobarbital, which is applicable. Other treatment, antibiotic for a prevention of infection or suspicion of other diseases, and also antiviral drug we are practicing for herpes simplex. It is effective as acyclovir. 14 days should be given, 10 mg per kg 8 hourly. And broad-spectrum antibiotic may be added for secondary infection. Anti-malarial if it is suspected case of cerebral malaria. So there might be some raised inhale pressure or papilledema and deterioration of consciousness. So we should give to reduce the cerebral edema, steroid, even the mannitol, and also treatment of hypoglycemia and treatment of shock, etc. I am not going detail because it's a common practice to every patient. So we must take the care of the unconscious patient, respiratory support, nutritional support, maintaining of fluid electrolyte balance, and also maintain intake output charge, and also the respiratory support of the infected patient. And sometimes we need, if it is in the Upazila Health Complex, we need to support a district or medical college, or if there may be from the general ward to ICU, if there is a evidence of respiratory failure or mechanical ventilation, etc. One thing is there should be monitoring follow-up of the patient at least 2 weeks from the after discharge, because there might be some mental or structural abnormality may develop, even the swallow, speech, uncontrolled seizure, there may be residual paralysis, and also the monitoring of the daily activity of the patient. So it is the disability of the patient should be monitored at least 2 weeks from the discharge, and should be carefully follow up the patients, those who survived after the event. So how to prevention is better than cure. So we have to prevent it from bat to human transmission or human to human transmission. And so we have to adapt some strategy or planning for Nipah virus transmission in our country by doing some awareness program. There is some Bengali leaflets, I will show it later on, and early case detection, case management, and infection control program, starting from the home, community, and the hospital. And we also prevent ingestion of raw dead palm sap, which is contaminated by the Nipah virus. And also we should prevent the contact of this vector, the fruit bat, to the palm juice by applying some mechanical barrier in the trees. I'll show how to prevent this contact with bat with the dead palm juice. These are the very simple method used by the jute. We can cover the whole the container, and also by dhoncha, named in case in the North Bengal, some bamboo stick, even the polythene. So it is a simple method. We should aware the farmers how to prevent contact with this bat with the palm juice. Prognosis is dependent on the cause and severity of illness and percentage and comorbidities, and also mild cases recover usually within 2 to 4 weeks, but severe encephalitis can lead to some dangerous complication, even the hearing, speech, blindness, permanent brain and neurological damage, behavioral change, cognitive disabilities, and also post-encephalitis syndrome, convulsion, and some sorts of memory loss. So the neurological sequelae may be sometimes after recovery, they may persist. And the outcome, it is shown from the bat to in the horse, in the Hendra virus infection in Australia and Nipah in the Philippines, the mortality rate is 60 to 80%. Nipah in the Malaysia and Singapore is mortality also less, that is 40%. But Nipah virus infection in Bangladesh, India, around mortality is 70 to 90%. So there is a high mortality in Bangladesh, India also, and in the Australia, it a bit lesser, but it was less in Malaysia. And the Malaysia epidemic also, that epidemic in 99 also, by the killing the pigs, they totally closed the epidemic, subsequent epidemics of Nipah in infection in Malaysia. And there is some ongoing trial on vaccination for prevention of Nipah virus infection. There are ongoing trial in the animals. There are 4 platforms they are trying to use. One is the recombinant measles virus, that is a group of paramyxovirus. Another one is the recombinant vesicular stomatitis virus vaccine. Another was from mammalian cell vaccine, but these are actually ongoing trial and to reduce the transmission of the infection in the community. So these are the awareness program. We should give these posters in different places of nipah endemic zone. The public should be aware about the খেজুরের কাঁচা রস খাবেন না, কোনো ধরনের আংশিক ফল খাওয়া যাবে না, ফলমূল পরিষ্কার পানিতে ভালো করে খাবেন এবং নিকটস্থ হাসপাতালে আক্রান্ত রোগীকে দ্রুত হাসপাতালে নিয়ে আসুন। এই ধরনের যদি লক্ষণগুলি দেখা যায়, জ্বর সহ মাথা ব্যথা, খিঁচুনি, প্রলাপ বকা, অজ্ঞান হয়ে যাওয়া, কোনো ক্ষেত্রে যদি শ্বাসকষ্ট হয়, তাহলে অবশ্যই রোগীকে নিকটস্থ হাসপাতাল, এই ধরনের যদি আমরা মাইকিং বা পোস্টারিং বা অ্যাওয়ারনেস প্রোগ্রাম করতে পারি পাবলিক কমিউনিটির মধ্যে, হয়তো তাইলে আমাদের এই নিপার ইনসিডেন্স অনেকাংশে কমে যাবে। So what we have to remember, acute encephalitis is a medical emergency. Any patient with fever with impaired mental state or neurological examination should be evaluated for encephalitis. Diagnosis of encephalitis mainly clinical. Do not forget the value of good history and physical examination. All suspected cases of encephalitis should be reported to the local authority to prevent further outbreak or further incidence of the cases in that locality, especially the civil surgeon. So what is our key message about the nipah? Nipah infection in human causes a range of clinical presentation, wide variety of presentation, from asymptomatic incubation to acute respiratory infection and fatal encephalitis. The fatality rate varies from country to country, from the 40% in the Malaysia up to 75% in Bangladesh, India. And this rate can vary by outbreak depending on the local capability of epidemiological surveillance and clinical management. In our country, there is a acute meningoencephalitis surveillance ongoing by World Health Organization in different parts of the world, different parts of the country. Nipah is transmitted to human from animal, bats or pigs, or contaminated food, or can also be transmitted directly from the human to human in Bangladesh, what we have seen. Fruit bat or pteropody family are the natural host of nipah virus, though they are not affected. Till today, there is no treatment or vaccine available for either people or animal. So primary treatment for human is supportive care and early diagnosis and prompt management. 2018 annual review of World Health Organization Research and Development Blueprint list of priority diseases indicate that there is an urgent need for accelerated research and development for nipah virus. সবাইকে বসন্তের শুভেচ্ছা। Thank you very much, BD Physician, for organizing such seminar, and thank you our chairman sir to preside the meeting on this occasion. Thank you everybody. Thank you the audience for patient hearing.